Hello, welcome to the 40th Annual North Carolina Ultrasound Society Symposium. This was supposed to be our 40th anniversary, and it was supposed to be a big deal happening in Asheville, North Carolina. And thanks to COVID, that was postponed. And instead, you get to see us all virtually, which is just fantastic. But my name is Jeff. I wanted to go over some pediatric stuff. Specifically, I wanted to talk about doing a full, complete pediatric echo, kind of in accordance with a lot of using guidelines from the IAC, from the ASE, as well as taking care of your doctors, whether they're reading in-house if you have pediatric cardiologists, or if you're having to read from, or other doctors are reading from a remote site. Most important thing I think to remember with doing a pediatric study is to have a very good and detailed protocol. And if you're in-house, then it's very easy. You sit down with your doctors, you ask them what they want to see, you sit down and look at the IAC website, and you make sure that you're covering all the bases with them, whether you're accredited through IAC or whether you're not. It's always good because at some point in time you're going to want to be accredited with the IAC. So you sit down there, you do that, and then you come up with a good working protocol. The reason these are important is you're trying to limit missing anything. Now, we all know throughout our careers we are going to miss something. It will happen. But we want to take as much of that out as what we possibly can. So, without further ado, I'm going to go over and show you what we do here as our protocol. And I'm going to go over some of the generals, and then I'm going to try to demonstrate a little bit some of the hand positioning for the people that do not do this on a day-to-day basis. So we're going to start right over here. I can turn that. So of course we start out with our parasternal long axis view. Just like with adults, with anyone else, this is the standard opening view. We take these measurements. That doesn't have to be a part of anyone's protocol. It just happens to be here. The next thing we do is we try to sweep inferiorly down to. Well, I'm trying to pause it. There we go. Whoops. So we try to sweep inferiorly down to the tricuspid valve, and then we'll sweep kind of anterior and superiorly to the pulmonary valve. And the reason we're doing this, we want to make sure that we catch, that we're not missing any type of VSD, whether it's an inlet or an outlet or even muscular. We want to make sure that we catch anything that we can see visually. So if we're seeing it with our eyes, it must be fairly big. We're also looking, we can see part of the atrial septum. We're making sure that we're not missing any pericardial effusion, that we're seeing all four chambers of the heart in one quick little sweep. Then we'll do the exact same thing using color. And once again, we're doing the exact same thing. We're evaluating this so we can see our ventricular septum here all the way through multiple planes down to our tricuspid valve inflow, and then back up to our pulmonary outflow. And if you pay attention through here, we're actually picking up on something right in here. Get rid of that. We're actually picking up on something right in here. So, and we'll go along and if anyone wants to take a guess at what it is right now, feel free, write it down on your own piece of paper. It's all on it's all on you right now. So then, of course, we can take, if we want to take our measurements, we can look at the pulmonary valve. If we needed to do any annular measurements, main pulmonary artery measurements, we can do that through here as well on a 2D image. I also, at the very end of my parasternal long axis, always like to take and put color flow going across the ventricular valve, or I'm sorry, across the ventricular septum. And you can see all the way through here, I'm scanning kind of in and out of the plane, and you can see that over here as I'm kind of still going superior and inferior. And I'm also rotating the probe a little bit left and right. I want to make sure I catch as much of this ventricular septum as I can. A lot of times for our younger babies, you'll see that we lower the scale up here, sometimes down into the 40s, mid 40s, upper 50s, somewhere in there. And this is just our parasternal long axis, or short axis. I like to do just kind of a full sweep real quick, all the way down to the very apex. And you notice when we say apex, we actually mean at the very most distal portion of the heart. So you can watch actually this whole apex disappear. And we do that so when we put our color on there, we're limiting ourselves from missing an apical muscular VSD. So now I try to do a couple of 2-beat clips. First one I like to show just kind of the pulmonary artery, the pulmonary valve. And the next one is just kind of get a decent picture looking at the aortic valve, make sure that it's tri-leaflet. And we'll get another one looking at the mitral valve. Another one at the papillaries. And another one at the apex. In pediatrics, we still do M mode, which probably a lot of adult sonographers probably find archaic, but I think it still has a very relevant position in our world, and it is very quick, very, we can gather all the information we need in just a matter of a few seconds, and we don't have to scroll back and forth. It's all right there on the same page. And the other reason we use this is that in pediatrics we tend to use the fractional shortening number. It's actually a much, we find it to be a much more reliable, much more accurate number than this, than that. So we have that. We'll look at the left atrium, the aorta. We look at the left atrium to aortic ratio. And we'll come back over here and we'll look at our pulmonary valve now with color. So one thing that you need to, we're starting to put pieces together. So whenever I'm teaching people, I may as well just do this same way I would if there was a student here or a new sonographer. I say you have to start creating a differential in your head. You have to start coming up with what is happening. So we have our scale here at 108 centimeters per second, but we're seeing some flow turbulence right through here. I would imagine this is going to be around 2 meters per second or so. So it's not incredibly high, but it's there. And then we had that kind of strange looking flow in our parasternal long axis. So now you have to start putting in your head what could be a possible explanation of this. That's what I mean when I say you have to create a differential in your head of what is going on. So lo and behold, there we go. 2.1 meters per second. Typically anything above 2, I like to do a VTI. It's not required, but I like doing it once again, one measurement, you get the maximum velocity, max pressure gradient, and the mean pressure gradient. Then of course I put a little bit of color across the tricuspid valve. And you also have to notice that there's some this big additional flow coming in right through here. Now we're going to do a sweep all the way down using color, all the way down to the apex. And you can see through here I've also lowered the color scale down to the low 50s. And we go all the way down once again until this ventricle disappears. And we're looking for any color through there. The last couple pictures here, we're looking at the right coronary artery. I like to do a still frame, and then I'll do kind of a color compare, showing that there's actual blood flow within that. Same thing over here with the left, our left main, left anterior descending. Not one of my prettier pictures, but there we go. So now I'm just doing this random measurement over here. And this is looking at a rim, this is kind of the aortic rim looking at a potential aortic or a atrial septal defect. So once I do that, I'm back here. We're in our 4-chamber view, just a normal 4-chamber view. Only difference is it's inverted. And I know that that throws people, but it really shouldn't. The colors will remain the same. You know, it's still red coming from the mitral valve, the same as it would if you had it turned the other way, doing an adult study. You know, the atrioventricular valves, it's still red. The insufficiency jet will still be blue. Everything's the same. This is still the left side, still the right side. Now we're going to do another little sweep here. This time we're going as far anterior as we can. So we start somewhat posterior. And I know that I'm posterior because I can see this structure here, which is the coronary sinus. There's a better picture of it. So here's our coronary sinus here. Something interesting to make sure that you note that if you see the coronary sinus, you don't see the atrioventricular valves opening and closing. And that becomes very important if you're trying to differentiate this from a primum atrial septal defect. You want to make sure that you can see the valves opening and closing. So when we're here, we can see the primum region is completely intact. We can see both atrioventricular valves, and we can watch them open and close. So now we will take a look at of course, the mitral valve, make sure that there's no insufficiency. We also take a quick look. We can see left pulmonary vein here. We can see a right pulmonary vein here. So we know we don't have a total veins. We can't rule out a partial anomalous pulmonary veins, but we know we don't have total. And of course our mitral inflow. Then we're going to look at our aortic outflow. And you see, I always pulse just before the valve in the LVOT, just at the valve, and then I'll do a continuous wave just to make sure I'm not missing something. Which brings up an interesting question. What is this background flow? It's probably something that we've seen, and in reality it is. We're actually starting to pick up some of the right pulmonary artery flow that's coming right back up here. And you can see that would be right around probably what we were looking at before, around 1.6, 1.65 maybe. And of course we'll look at our tricuspid valve right in here, and you can see this big flow coming down. And as I've alluded to before, that's actually an atrial septal defect. So now we're just looking at that pulmonary artery one more time, making sure that there's no little VSDs also in here. I take another measurement, looking kind of at the mitral level here, looking at that. So we're taking all these rim measurements for the doctors, specifically for the interventional cardiologist if they choose to close this secundum atrial septal defect. I personally always do a 3-chamber view. I like it because if I do have any anomalies with the mitral valve or aortic valve, I can get another good measurement here. I'll also slide into a 2-chamber view if needed, but I always do this one because I also like to do with the color. I still do my sweep showing just what we had at the very beginning. This is really just another angle of the peristernal long axis. That's all this is. That's why we call it the apical long axis. When we come down here to our subcostal, first thing we like to do is just take a regular anterior posterior view. So we end up with, of course, our liver. The bulk of it is going to be over here on the right side. Our inferior vena cava is here. Our abdominal aorta, our vertebral process is here, and we're making sure that we're just getting our abdominal situs normalized here, so we know everything is going to where it's supposed to be going. Then I'm going to do a sweep, and we're going to start really just from that up and down position, and I'm just going to go I'm going to go cranially. Basically, I'm sending that sound being going towards the patient's head, and then I'm going to rotate a little bit counterclockwise, and then angle to the patient's right shoulder, left shoulder. So if we were doing that here, we can see I have the dot holding right here. I'm down here on the patient's belly. So I'm going to start straight up and down, and I'm just going to slowly angle down like so. I'm going to rotate the dot right up here, so now it's coming closer and closer to 12 o'clock. And then I'm going to angle the sound beam over to the patient's left shoulder. And what that's going to do is, I'm doing that, we're going to see, one, we get our 4-chamber. It opens up as I rotate slightly counterclockwise. It starts opening up the inferior vena cava, and as I angle towards the patient's left shoulder, we'll open up the abdominal aorta. And then we're going to do that exact same thing, but using color. We always like to take a look at the abdominal aorta. The reason we do is we want to see a rapid upstroke, rapid downstroke. If you have any of this diastolic runoff through here, that means that you will have a coarctation of the aorta. From here, I'll take another look. This is our kind of subcostal 4-chamber. This is a beautiful view if you want to get like a whole septal measurement through here. It's an excellent view to get that. From there, I'm going to slowly angle as far anterior as I can. And we know we're anterior once we hit the pulmonary artery. Once again, just measuring the different rims. Once you do all of that, you'll also have, you add all those together, you'll have your total septal length. And I try to get just a color view. Sometimes the babies are moving around a little bit, and it's hard sometimes to differentiate what is superior vena cava flow versus the atrial defect flow. And the reason I picked an ASD PFO is very commonly seen, especially in our young children. So from here, this is called our bicaval view, and it's very easy to get. So all you have to do, once again, when you're starting, you'll start in your complete anterior posterior view. You'll keep angling down until you get a nice 4-chamber view, and then you just slowly rotate your dot down to about 6 o'clock. And once you get that, you get this beautiful superior vena cava and your inferior vena cava. And this is very important because this is one of the only views where you get to see the superior portion of your atrial septum. And if you miss something, if you miss that, you may miss a sinus venosus atrial septal defect on the superior portion of that. But as we're looking through here, you can see that there's a nice little tissue flap here. You can see the defect is right in there. And it's big enough that it is causing some right-sided dilatation, but it's not that big. It's not terribly big. Then once again, we scan all the way back down to the apex, the far apex. And then we'll do the same. I like to just show color on here one more time. We can see blood flow going across that atrial septum. And then I'm going to pulse in that. The reason we want to make sure that this is one that it doesn't have a restrictive appearance. A restrictive appearance would be, one, it could be a high velocity. Two, it may be more of a continuous flow. But we just want to make sure that it's not, we want to make sure that it's non-restrictive. And we can do another measurement. This is great because we're actually getting our inferior rim and our superior rim, which are both very important to the closure devices. So now we come up here to our suprasternal window. And the way we get this, and I know there's probably a lot of pediatric sonographers and adult sonographers that do this, but I've still run into several people that have a hard time with this. Now, one of the key things that you can take home with this is that this is, I didn't have this baby's neck arched back far enough. And, you know, the reason I didn't is they were a little bit fussy, and they had nothing to do with the coarctation. They weren't here for that. This was actually for a follow-up of that ASD, and they were getting a little bit fussy. If I was up on the NICU or the PICU and this was a brand new patient to us, I would actually put a nice big roll behind their neck. And when I say a roll, we'll just use this as, I mean, you'll take several washcloths, and if it's a little tiny baby, I may just roll it up like so, and just kind of put this under their neck. The goal is really just to have their neck come all the way back. If it's an older kid, I may use a towel. Sometimes I use a pillow in our room or their room to get their neck arched back. And you can always tell if it's not. You can always tell here because this comes out and down like so instead of coming up and straight down. So, you know, I chose this. I did this for partially just for teaching to see what it looks like, and partially out of wanting to get the best images that I could for this child. But the best way to do this is you have their neck arched all the way back. You're going to put this probe directly in this notch right up here, the suprasternal notch. You're going to get that thing right in there. You don't have to jam it because that's not going to make anyone very happy. But you set that on there, and then you can just kind of slide the probe around or angle left and right in order to get a nice picture. And this isn't a bad picture. We can still see all three head and neck vessels, but it could have been better. I always like to get a nice descending velocity, an ascending velocity. And here's another thing that we like to do as well. It's hard to tell, but what I'm doing here is in this split screen, I'm actually scanning over to the patient's right, and I'm showing the superior vena cava. And then I'm going to scan over to the patient's left to make sure that we're not missing a persistent left superior vena cava. The next thing we're going to do is determine arch sidedness. And you can see this little baby was giving me the business here. But what we're looking for is, as this innominate artery comes up, we want to see that it branches into the right common carotid and the right subclavian. And the reason we do that is we know, the innominate is the only vessel up here that branches off early on. It's the only one that branches early. And we know that it should go off to the patient's right, and if it does, that means that the arch goes off to the patient's left. I was just going through it a couple times here. Then I finish up once again looking at the pulmonary artery here. And you can see there's a little bit of a flow acceleration across the left pulmonary artery and a little bit across the right. And then we'll finish up by looking at the 4 pulmonary veins. So up here is our left and right upper. Down here is our left and right lower. And that is a complete, it's a complete pediatric echocardiogram, following our protocol, making a few adjustments, for the atrial septal defect, and sometimes making a few adjustments for, babies just tend to get very agitated, and you never know when they're going to become agitated. So you sometimes just have to make quick little adjustments to make sure that you're getting all the information and presenting it in the best way that you can. So now we're going to kind of switch gears, and we're going to look at a few that, I think are interesting, that if you didn't follow the protocol, you may miss. Okay. All right, so now let's take a couple of quick peeks here. So this first one we're going to look at, we have, once again, we start out on our parasternal long axis. We're doing everything that we should. And we're going to do our sweep here. And now we find something somewhat interesting. What in the world is that? That doesn't look like it belongs there, but it looks real. Real enough that I decided to measure it. So what we're looking at here is our left anterior descending. This is our pulmonary valve through here, pulmonary artery, left pulmonary branch. The left main will be somewhere right in there, kind of buried. But this is our left anterior descending. This was a patient with Kawasaki disease. Oddly enough, going into this whole new world of COVID and all that, with the multi-system inflammatory disease in children due to COVID and Kawasaki's. Now we have two things that we always have to keep an eye out for: coronary arteries. This happens to be one of them. That, if this was not on if this was the only picture that you did, you may miss that. At least until hopefully you would have picked it up once you got into your short axis. But once again, we can see it through here as well, even as we start our sweep there. There it is right there. It almost looks like a big megaphone. There's our left main coming in and out of view there. So here's our right coronary artery. We're just showing flow in there. Here's our left main, and then we'll try to get the best picture. Nice thing to do with these is you always want to follow them out as far as you can go. Take serial measurements, especially once they start getting up to this size. This size is really when you really start worrying about thrombus, and you really start thinking about maybe having to put them on Coumadin at this point as well. I just wanted to go along with this one and show kind of that you can see these even from like the apicals, especially the LAD. So we're right in there once again. So there's our right coronary artery, and here's our left. So there's the left main, there's a left anterior descending coming all the way down through here. This is nice, you know, chances are good I'm not going to measure it, but this is a great place to put color on. It's also a great place, you know, you can see a long segment of it, try to look for thrombus. I did measure it. As you can see, we can actually see it running all the way down, really to the apex of the heart. So there's another one. This is one. So we're going to switch to another one. And now this one's just for fun. I don't think anyone would miss this, because you can already see something funky going on up here with the right coronary artery already. It almost comes up and looks like a T. So hopefully no one would miss this. I just thought it was really cool, so I wanted to throw it in here. So of course here's our right coronary artery coming up, and here's the T portion. So looks like a vessel there, looks like a vessel there. So I put color on here to see what we can see. And now you can see this color flow coming up through here, kind of branching off over here. It's going to be difficult to see because this is really, you know, really kind of, it's not in a great window to see color, but we can definitely see this color coming up through there. But now we can see it. I've angled this slightly different, so we can see this flow coming up. There we go, there's a little flash. And then we see flow through here. Here's our systolic, and we're already down here in kind of the diastole. So we know it's coronary. So now I've rotated into our parasternal short. Now you can really start seeing that there's this vessel, and then there's this very long vessel coming all the way over here. Nice quick still frame of that, and then we'll put color into it. Oh, look at that. So oftentimes coming off of the right coronary artery, you may see what's called a little conal vessel. But it's very small, very narrow. It comes over here, kind of helps feed this conal area, but it'll kind of just feather out and just kind of peter out as it gets to its position. This, however, is actually the left anterior descending, arising from the right coronary artery. It's a normal variant, but you know, once again, it's one of these things. This kid was here at one point, just to get an echo, maybe for chest pain, maybe for a murmur, who knows what, syncope, who knows. This was an incidental finding that we found. And that's the joy of doing pediatrics, is that every once in a while you just come across something that is extremely, it's not common, and it's just very interesting to watch and to try to track down. So you try to follow that all the way out and really just kind of show off for the camera. There's a nice distal section of that left anterior descending that we can see. And then we'll come down to, there's another picture. I got a little heavy-handed. He was so photogenic. So then we do our measurements, but I also wanted to show it down here from his apical window. And here's a nice picture of it. You can definitely see that this vessel is coming all the way, and it's going to run all the way down the ventricular septum, really proving that that is truly the left anterior descending. So just, I think everyone would have seen that, but at least we can put a name to it, and once again emphasize that when you're doing pediatrics, anything is almost possible. That's the joy of it. Alright, so this next one we're going to look at, of course, involves us coming up here, looking at the arch. And you can see we're starting off in the same spot, you know, getting our descending velocity, we'll get our ascending velocity. Now I'm going to scan over. I'm looking for the right superior vena cava, and then we're going to scan over here, and lo and behold, we have this flow, which is our persistent left superior vena cava. And the only reason I bring this up really is, one, you can see as we start going through here, there's no innominate vein, or what sometimes people will call the bridging vein. There's no bridging vein. So the only importance of this persistent left superior vena cava, one, is that it's going, typically it drains into the coronary sinus, so you're going to see a dilated coronary sinus, and we'll go back and look at that as well, you know, to show where the coronary sinus is, how we know from the get-go to look for that. But the important thing to note with this is really if they get older and they need to have a pacemaker. If it's well documented that they have a persistent left superior vena cava, the physician is not going to try to put that lead in over on the left side. They'll have to put it in over on the right side. Saves the patient an incision, and it saves a lot of time with the person putting that pacemaker or ICD implant in. Because if they're trying to, normally, you know, most people are right-handed, so they're going to try to put it in on the left-hand side. So if you have a left SVC that's going to the coronary sinus, that electrode is going down that SVC into the coronary sinus and then into the right atrium. It takes too long of a route, and they're usually not going to ever use that unless they just have to. So now this is always an interesting view. When you get it just right, you can actually see both superior vena cavas coming down through here, just like so. Of course, this one's dumping directly into the right atrium, and this left one is going to go into the coronary sinus. But it's very, very pretty, especially when you can get that. And you also have to note this for some kids that are going to go into surgery for, let's say it was a hypoplastic left heart syndrome, and they're going to end up getting a Glenn shunt. It's always nice for the surgeon to know, hey, you know what, they actually have two SVCs, so they'll actually do a bidirectional, you know, bilateral Glens coming up here. But it's nice for them to know. Alright, so here we are back at the same pictures that we'd started on the same person. So when you look through here, this is their coronary sinus right in there, and you can see that it is quite dilated. And when you see it, especially real time there, you can see that it's nice and dilated. If we come back over here to his apical images, it's just a few clicks away. There we go, almost there. Almost there. There we go. Now we can see this is me angled posteriorly. So we'll come back over here. And you can see this is the coronary sinus right here. And you can see Even from what we saw as a normal in the other room, this is actually much bigger. It's quite dilated, and that right SVC will be dumping straight into it. Okay, so this is going to be the last one that we'll look at. I think of all of them, this is probably the most telling, this kind of the scariest one, really, of what you could miss if you don't follow a very good protocol, and what sometimes people can miss even following good protocol. So we start out, we're looking at this nice normal looking heart. Normal left, it looks like the normal left ventricular dimension, normal right ventricular, normal left. Everything's looking normal. We just kind of keep following through, not seeing any color flow going across there. I didn't see any color flow coming across through here. Here we are, nice coronaries. We're doing our sweep. Our atrial septum looks great. Our pulmonary valve looks fantastic. No, when we get over there to it, there's no velocity increase across that aortic or the pulmonary valve. Nice normal measurements once again. And here's our velocity. Everything looks amazing. It's beautiful. There's times that you almost start going into autopilot because everything is looking so pristine. You're like, okay, I'm going to finish this up and we're going to be good. Even through here, atrial septum looks intact, ventricular septum looks intact. Pulmonary or the coronary sinus doesn't look dilated. We have normal flow velocities everywhere so far. And we're just humming right through here, just as if we were doing this. Kind of start turning your mind off, you're thinking about the next patient. This next one I've got to focus on the Glenn shunt, or I need to focus on a Fontan, or I have to do this, or it's a bicuspid valve. I want to make sure I have everything that we need. And you just keep on trucking through here. Everything is looking intact. Nothing is... And then all of a sudden, we come into this view. And I don't know if you saw it right away, but there's something that doesn't look right here. It looks like there's a gap there. So then you come back up here and you're like, oh, I wonder. And then you're starting to see a little bit of blue flow in there, mixed in with some of this superior vena cava. Remember, this is our bicaval view looking at our superior vena cava, the inferior vena cava. And when you look, it just looks like there is some flow crossing over here. You can see some tints of blue coming in through there. And of course, sometimes as it comes out, it's going to come out straight down and gets muddled in here and becomes kind of a reddish color. So you have to kind of stay on top of it. And we come back through here, and you see now I've kind of gone at a different angle. I want to make sure that this is truly what we would call a sinus venosus defect versus a high secundum atrial septal defect. So if there's any tissue involved up here, then it's a high secundum. If there's no tissue involved here, then it's called a sinus venosus. So when we really kind of slow this down, some telltale signs. Here we have our atrial septum. This is the superior vena cava. And almost like a tetralogy, it almost looks like it overrides. It almost looks like the two of them override. And that's kind of a soft giveaway, but it's not a guarantee. But now as we start changing the angle a little bit, we start noticing that there's more blue flow. There's some flow coming across through there. And when you get this nice view, it looks like that is a nice smooth area. And it's always important to note with these sinus venosus atrial septal defects is that they have a strong correlation with partial anomalous pulmonary venous return. Specifically, or typically I should say, it's usually the right upper pulmonary vein that will drain into somewhere along on the SVC. So now we're measuring it. I'm trying to convince the cardiologist that this is truly a sinus venosus. So as I was saying before, this is really one of the only views that we can see this defect. So if you didn't do this view, you would have missed this defect. And that's one of the take-home messages. Not that this is a scary lesion, but it does require surgery. But if for any reason you didn't get this picture, there is no way in the world that you would have seen the sinus venosus atrial septal defect, because between this and a high right peristernal low suprasternal view, those are the only two views that we have in echo to see this. And there was no telltale signs. The right side was not dilated. There was no flow acceleration across the pulmonary artery that couldn't be explained away. These are the things, everyone always assumes it's the giant things that are going to keep you awake at night. Oh, did I miss a TET? Oh, did I miss a hypoplasm? No, you're not going to miss those things because they're glaringly obvious. There's big holes. There's things going in places that they shouldn't be going. It's these little things that will keep me awake, because these are so easy to miss. So then we just kind of keep trucking along through here, and I'm going to come up here in just a moment, and we're going to show the other picture of how you can get this. So the easiest way, and here's a nice look at this innominate artery branching into the right subclavian and the right common carotid up here. So here's the other thing. I am looking at these pulmonary veins, and sometimes they're hard to see, and this was one of those that was just difficult to see. So here's this view. So here is this high right peristernal or low right suprasternal, however you want to look at it. What we're looking for this SVC flow coming down. This is our left atrium here, our atrial septum, and our flow going across that sinus venosus atrial septal defect. So SVC is coming in here. There's our flow. The way I like to do this, and it's hard to do if the kid is screaming or crying, but I try to follow the superior vena cava as far down as I can until I know that it's directly in the heart, and then I'm going to start rotating a little bit clockwise until we get, and you can see this kiddo is starting to become a little bit agitated. So I was just trying to track down, get the best picture I could. But really nice. So here's our SVC coming in there once again, and that is our sinus venosus defect right in here. This really pretty picture when it finally comes in. So we can see color coursing across. We can see the 2D over here. We can see that there's no rim of tissue in here. Of course, our SVC is coming down here. And that is something that you would 100% miss if you didn't do that bicaval view. Because most people don't ever think about doing this view. This is something that on a bigger kid, a big teenager or adult-sized patient, it's kind of murder to get. This was a younger person, and it was still kind of, it's still a little bit tricky. but on adult-sized patients, it's very difficult. Then I was trying to track down the right upper pulmonary vein. I declared in my own way that it was anomalous. We ended up getting a CT scan. It was anomalous. This was a superior sinus venosus atrial septal defect, and it was closed, and this person has done very well, as to be expected. So that is my lecture. I hope everyone learned something. I am eternally grateful that everyone has decided to show up for these virtual meetings. I think the North Carolina Ultrasound Society is an amazing institution. I have nothing but kind words. I think everyone should try to nominate people to be on the board of directors. Every year we also have a Sonographer of Excellence Award. I think you should nominate people for that you think would do very well. And I truly appreciate everyone taking the time and coming out, and we are very grateful. Thank you very much.